Hello, my name is Scott Urquhart, and I'm chair of the Metabolic and Endocrine Disease Summit. We are now in our 4th year and 7th meeting here in Orlando, Florida, 2014. We've had a lot of great lectures, and one of the several lectures that I presented with my co-chair was Chris Sadler, and we answered the call of a lot of our attendees in how do we address the complexity or overlap of vitamin D deficiency, hypercalcemia, and then parathyroid disease. So what we were able to do in this 45-minute interactive lecture was really discuss with attendees the key factors and features that are most important in that visit with your patient. The important thing to look at is vitamin D is very common, and we look at the factors that are risk factors for vitamin D deficiency, being elderly, overweight, African American, dark-skinned individual, institutionalized patients, elderly who don't get outside. Importantly, is patients using an SPF of number 8 or above blocks out 95% or more of the ultraviolet rays necessary to produce vitamin D, and that's a prudent thing to do with the avoidance and prevention of skin cancer and skin lesions that are sun-related. In addition, GI malabsorption syndromes such as celiac disease, post-surgical patients, bariatric surgery. Addressing the guidelines, the Endocrine Society 2011 guidelines recommends a vitamin D of 30 or greater, and ideally around 40 to 60, most notably because of the association of improved bone health with normalization of vitamin D. With regards to calcium, that's where a lot of phone calls I get from colleagues is I have a hypercalcemic patient, or the patient is referred to me for hypercalcemia in the mild range being, let's say, for instance, 10.2 to 11.5 milligrams per deciliter. What do we do with the hypercalcemia? What does it mean? How do we appropriately work it up? And the things we have to look at is really, do they have parathyroid disease and do they have vitamin D deficiency? Because the 3 real important tests are the calcium level, the albumin to look at the calcium, the 25-hydroxy vitamin D, and the intact PTH. Those are the things we're kind of playing with when we're trying to figure these cases out in the best direction to go. The prevalence of primary hyperparathyroidism and cancer, between the 2 of those, is about 90% of all hypercalcemia. And the prevalence of primary hyperparathyroidism is about 1 in 500, typically occurring in postmenopausal women. The workup is very important because a lot of times we'll get into unnecessary tests such as parathyroid scans. So usually we recommend rechecking the calcium the first time, checking an albumin with it, but doing it fasting because dietary and supplemental calcium can affect the PTH levels. So best to do these fasting and also to check the vitamin D. So a serum calcium intact PTH and a 25-hydroxy vitamin D. Once we have, if in fact identified hypercalcemia that is persistent, the workup or the criteria that we're actually looking for surgical candidacy will be a patient under age 50 years old, a GFR, glomerular filtration rate under 60, so impaired kidney function, looking at osteoporosis, and then having a calcium that's 1 milligram per deciliter greater than the upper limits of normal. 10 to, therefore 11 to, would be the surgical criteria. And if so, we look into doing cystoscopy scans, identify where the parathyroid adenoma is, and then send them to an appropriate, well-skilled surgeon to take care of these patients. And they have an outstanding life expectancy associated with it and improvement in bone density and osteoporosis. So, thank you.